The nervous system begins development at 3 weeks post-conception, making it the first organ system to initiate formation. This early timing has profound clinical implications for premature infants, whose brains should be developing within the protected uterine environment. Brain development follows successive genetic programs during distinct ontogenic stages. Each stage must complete properly before the next can begin. The neural plate forms at the beginning of the 3rd week, establishing the foundation for all subsequent neurological development. The critical period concept directly impacts our clinical practice. During specific maturational windows, the developing nervous system demonstrates heightened sensitivity to environmental stimuli. Pain, positioning, noise levels, and handling procedures can all influence long-term neurological outcomes during these vulnerable periods. While development largely completes by adolescence, ongoing neurogenesis throughout life provides potential for recovery and adaptation following early brain injury. This understanding guides our approach to neuroprotective strategies and developmental care protocols. This developmental sequence explains the vulnerability patterns we observe in premature infants. The process begins with neuroectoderm induction, progresses through neural tube formation, and advances to telencephalon development. Neurogenesis occurs most actively during the 2nd trimester, producing both neuronal progenitors and mature neurons. Extremely premature infants undergo this process outside the optimal intrauterine environment, creating unique challenges for normal brain development. Neuronal migration follows predictable patterns from deep brain regions to cortical destinations. Migration disorders visible on neuroimaging often result from disruptions during this phase. Programmed neuronal death eliminates excess cells, creating proper brain architecture. Neurite generation produces axons and dendrites forming communication networks. The brain initially overproduces connections, then eliminates unnecessary ones through synaptic pruning continuing into adolescence. Angiogenesis, gliogenesis, and myelination occur simultaneously, establishing supporting infrastructure. Intrinsic genetic factors control timing, while extrinsic environmental factors significantly influence outcomes. Our NICU interventions directly impact these modifiable environmental factors. Gastrulation represents one of the most critical processes in embryonic development, fundamentally reshaping the basic structure of the developing organism. During this phase, the simple bilaminar embryonic disc transforms into a complex trilaminar structure, establishing the 3 primary germ layers that will give rise to all organ systems. The ectoderm forms the outer layer and will eventually develop into the nervous system and skin. The mesoderm creates the middle layer, becoming muscle, bone, and connective tissues. The endoderm establishes the inner layer, forming the digestive and respiratory systems. This layered organization isn't arbitrary. It reflects the fundamental body plan that persists throughout development. The process creates a temporary neuroenteric canal that briefly connects the dorsal and ventral surfaces. More importantly, gastrulation establishes basic body axis formation, determining where the head will be, where the tail will develop, and how the back differs from the front. Without proper gastrulation, neurulation cannot proceed normally. This timing explains why environmental insults during the 3rd week of gestation can have such profound and lasting effects on neurological development. Neural plate formation marks the true beginning of nervous system development, appearing at the start of the 3rd gestational week in the mediadorsal zone. The location is precise, positioned just ahead of Henson node along the rostrocaudal axis, which determines the future head-to-tail orientation. Neural induction involves an intricate cascade of signaling molecules working in concert. Follistatin and noggin act as neural inducers, while notch signaling regulates cell fate decisions. Dorsalin 1 and WNT1 establish dorsal patterning, and hedgehog proteins create ventral identity. These aren't isolated events. They represent coordinated molecular conversations that establish the basic neural architecture. The establishment of dorsoventral polarity determines which parts become the back of the nervous system versus the front, while anteroposterior regionalization creates the foundation for brain versus spinal cord development. Vertical induction occurs through fibroblast growth factor 8 and mesendodermal factors, while planar induction involves the complex interplay between bone morphogenetic proteins and their inhibitors. Understanding these mechanisms helps explain why certain developmental anomalies cluster together and why timing of insults matters so significantly. Primary neurulation follows 4 distinct but overlapping steps that transform the flat neural plate into the closed neural tube. Neural plate formation occurs during the 3rd gestational week, establishing the neural ectoderm. Neural plate modeling involves both shaping and thickening of this tissue, preparing it for the complex folding process ahead. Neural groove formation, also during the 3rd week, creates the characteristic depression that runs along the length of the developing neural plate. The edges begin to elevate, forming neural folds that will eventually meet and fuse. Neural groove closure begins at the start of the 4th gestational week, proceeding in both rostral and caudal directions from multiple closure points. The temporal and spatial overlap of these processes is clinically significant. Problems during any step can result in neural tube defects, but the specific timing and location of the disruption determines the type and severity of the malformation. Neural crest formation occurs simultaneously, giving rise to structures we encounter clinically: dorsal root ganglia that process sensory information, Schwann cells that myelinate peripheral nerves, and the pia and arachnoid layers of the meninges. This coordination explains why neural tube defects often present with associated abnormalities in neural crest-derived structures. Neural tube closure follows a highly predictable sequence that begins in the region of the lower medulla and proceeds bidirectionally. Understanding this timing is essential because the specific location and timing of closure failures determine the type of neural tube defect we encounter clinically. The anterior neuropore closes at approximately 24 gestational days, while the posterior neuropore closes around 26 gestational days. The posterior closure site occurs at the lumbosacral level, which explains why spina bifida most commonly affects this region. When closure fails at the anterior neuropore, we see anencephaly or encephaloceles. When posterior closure fails, we observe various forms of spina bifida. The neural tube initially forms as a straight structure before brain vesicle formation begins. This straightforward architecture becomes increasingly complex as development progresses. The relatively narrow window between anterior and posterior neuropore closure, just 2 gestational days, demonstrates how precisely timed these developmental events must be. This timing also explains why folic acid supplementation is most critical during the periconceptional period, as neural tube closure occurs before many women realize they're pregnant. Primary brain vesicle formation begins before the posterior neuropore has even closed, demonstrating the overlapping nature of early neurological development. The anterior portion of the neural tube undergoes dramatic shaping to create 3 distinct primary vesicles, each destined to become major brain regions. The prosencephalon develops into the 4 brain structures, including the cerebral hemispheres and diencephalon. The mesencephalon becomes the midbrain, maintaining its relatively simple structure compared to the other vesicles. The rhombencephalon forms the hindbrain, eventually giving rise to the pons, medulla, and cerebellum. The prosencephalic phase and hemisphere formation span gestational weeks 5 through 10, representing a critical period for forebrain development. During this time, the prosencephalon divides into the telencephalon and diencephalon, and the characteristic cerebral hemispheres begin to form. This regionalization results from the same rostrocaudal and dorsiventral patterning mechanisms established during neural plate formation. The molecular signals that initially pattern the neural plate continue to refine regional identity throughout brain vesicle formation, creating the foundation for all subsequent brain development. Secondary neurulation represents a completely different mechanism from primary neurulation, forming the spinal cord caudal to the mid-sacral region. This distinction is clinically important because defects in secondary neurulation create different types of spinal abnormalities than those seen with primary neurulation failures. The process begins with canalization during gestational weeks 4 through 7. Rather than the folding and fusion mechanism of primary neurulation, secondary neurulation involves the formation of a solid cellular mass that subsequently develops a central canal through programmed cell death. Retrogressive differentiation begins in the 7th gestational week and continues after birth, gradually reducing the size of the secondary neural tube while maintaining essential structures. This process creates the ventriculus terminalis and filum terminale, structures we can identify on postnatal neuroimaging studies. The sequence begins with multipotent cells forming the tail bud, which then undergoes canalization to create the secondary neural tube. Understanding this process helps explain why certain spinal cord malformations occur in the lower sacral and coccygeal regions, and why these defects often differ in their clinical presentation from more rostral neural tube defects formed through primary neurulation. Neurulation failures create two fundamentally different categories of defects, and understanding this distinction is crucial for predicting clinical outcomes and planning management strategies. Open neural tube defects result from severe delays or complete cessation of primary neurulation, the process we discussed where neural folds must meet and fuse to form the closed neural tube. When primary neurulation fails, the neural folds simply don't close properly. This creates a bifid vertebral canal where the posterior elements of the vertebrae remain split apart, leading to open spinal dystrophism. The neural tissue remains exposed to the amniotic fluid throughout fetal development, causing progressive damage from both chemical exposure and mechanical trauma. Myelination represents the classic example. You'll see exposed neural tissue with cerebrospinal fluid leakage and progressive neurological deterioration. Closed neural tube defects follow a different pathophysiology. These typically arise from abnormalities in secondary neurulation or incomplete separation between neural and cutaneous ectoderm during early development. The skin closure occurs normally, but underlying neural structures develop abnormally. Spina bifida occulta, tethered cord syndrome, and lipomyelomeningocele all fall into this category. The timing of neurulation failure directly determines both the anatomical level and the clinical severity of the resulting defect. Earlier failures during primary neurulation tend to affect more rostral structures and produce more severe phenotypes with greater functional impairment. Later disruptions during secondary neurulation typically involve lower spinal segments and may present more subtly, sometimes not becoming apparent until childhood or even adulthood when growth spurts unmask tethered cord symptoms. Critical periods represent windows of heightened vulnerability when specific developmental processes reach peak activity and become most susceptible to environmental influences. This concept fundamentally shapes how we approach neonatal care because it explains why timing matters so much in determining outcomes. Each stage of brain development has its own unique vulnerability profile. During neurogenesis, the developing brain is most susceptible to factors that affect cell division and proliferation. Hypoxia, certain medications, or nutritional deficiencies can dramatically reduce neuronal numbers. During migration periods, different insults create entirely different patterns of injury, often resulting in cortical malformations rather than cell loss. Environmental factors during critical periods don't simply cause immediate damage. They can permanently reprogram developmental trajectories. This occurs through epigenetic mechanisms that modify gene expression without changing the underlying DNA sequence itself. Environmental stressors can create molecular marks that persist long after the initial insult, continuing to influence brain development and function for months or years. The transgenerational consequences represent perhaps the most sobering aspect of critical period disruptions. Epigenetic modifications can be passed to offspring, meaning environmental insults during critical developmental windows may affect not only the current patient, but potentially their future children as well. Neurogenesis follows a highly predictable timeline, with peak activity occurring during the second trimester, roughly spanning 10 to 20 weeks of gestation. This timing carries profound clinical implications for extremely premature infants, whose brains should be undergoing rapid neuronal production within the carefully controlled intrauterine environment rather than in the NICU. The neurogenic process occurs primarily in two specialized regions: the ventricular zone, which lies immediately adjacent to the lateral ventricles, and the subventricular zone positioned just above it. These proliferative zones function as cellular factories, generating the estimated 3 to 100 billion neurons that populate the mature brain. The wide range in this estimate reflects both ongoing research refinements and significant individual variation in final neuronal numbers. Radial glial cells serve dual critical functions during this process. They act as both neuronal progenitors, dividing to produce new neurons, and as scaffolding structures that guide newly born neurons from the proliferative zones to their final cortical destinations. These cells extend long processes that span the entire thickness of the developing brain wall, creating highways for neuronal migration. Disruption of radial glial function can result in both quantitative deficits, fewer total neurons, and qualitative problems like migration disorders, where neurons end up in wrong locations. Neurogenesis doesn't completely cease at birth. Specific brain regions, particularly the olfactory bulb and the dentate gyrus of the hippocampus, maintain limited but measurable neurogenic capacity throughout life. This continued capacity for new neuron generation provides a foundation for recovery and adaptation following early brain injury, offering hope for functional improvement even after significant neonatal neurological insults. Neuronal migration represents one of the most remarkable journeys in brain development, occurring during a critical 12 to 24-week gestational window when millions of newly born neurons must travel from their birthplace in the ventricular zone to their final destinations in the developing cortex. Understanding this process is essential because migration defects create some of the most severe cortical malformations we encounter clinically. The migration follows a precise radial pattern, with neurons moving along the extended processes of radial glial cells that span from the ventricular zone to the cortical surface. Think of these glial processes as guided highways that direct traffic flow during the busiest construction period in brain development. This isn't random movement. It's a highly orchestrated process where timing and direction are absolutely critical. The inside-out pattern of cortical development means that later-born neurons must migrate past their earlier-born neighbors to reach the outer cortical layers. This creates the six-layered structure of the mature neocortex, with the deepest layer 6 neurons arriving first and the superficial layer 2 neurons arriving last. When this process goes wrong, neurons end up in incorrect locations, creating the heterotopias and lissencephaly patterns we see on neuroimaging. The relin signaling pathway serves as the molecular traffic control system for this migration. Relin protein, secreted by Cajal-Retzius cells in the marginal zone, provides the stop signal that tells migrating neurons they've reached their proper destination. Mutations in relin or its receptors result in the classical inverted cortical layering seen in lissencephaly, where the normal inside-out pattern becomes completely reversed. Cortical development involves a precisely timed sequence of folding events that transform the initially smooth brain surface into the complex gyral and sulcal patterns characteristic of the mature human brain. This folding process isn't simply about fitting more brain into the skull, it reflects fundamental organizational principles that affect both structure and function. Primary sulci formation begins remarkably early at 13 weeks gestation, establishing the basic architectural framework. The insula represents a particularly important landmark in preterm brain development. Operculization of the insula begins around 20 weeks and completes by 28 weeks gestation, providing a reliable marker for assessing appropriate brain maturation in preterm infants. When we see delayed or incomplete insular operculization on neuroimaging, it often indicates broader developmental delays. Secondary and tertiary sulcal formation occurs between 23 and 28 weeks in utero, coinciding with the period when many of our most premature infants are born. This timing explains why extremely preterm infants often show simplified gyral patterns on early neuroimaging studies. Their brains simply haven't completed the normal folding process that should occur in utero. The developing cortex shows a distinctive 5-layer pattern at 16 to 18 weeks, quite different from the 6 layers of mature cortex. Subplate neurons play crucial roles during this fetal period, serving as temporary relay stations for incoming connections and guiding proper circuit formation. These neurons normally undergo programmed death by term, but their premature loss due to injury can disrupt normal connectivity patterns. The cortical surface area expands dramatically during this period without proportional thickness increases, requiring the folding process to accommodate this growth within the constraints of the skull. Programmed cell death, or apoptosis, represents one of the most counterintuitive yet essential processes in brain development. Rather than representing pathology, this cellular suicide program eliminates excess neurons and refines neural circuits to create the precisely organized mature brain. Understanding normal apoptotic patterns helps distinguish between physiological cell death and pathological cell loss in clinical settings. The process operates through a delicate balance between survival signals and death signals that each neuron receives from its environment. Neurons that successfully establish appropriate connections and receive adequate trophic support survive, while those that fail to integrate properly undergo apoptosis. This isn't random elimination. It's a competitive process that ensures only the most functionally relevant neurons persist. The molecular machinery involves caspase cascade activation that leads to systematic DNA fragmentation and cellular dismantling. This process is so tightly regulated that dying neurons can be eliminated without causing inflammation or damage to neighboring cells. Electrical activity plays a critical role in determining which neurons survive. Those that participate in meaningful neural circuits receive survival signals, while inactive neurons are eliminated. The scope of normal apoptosis is staggering. Up to 50% of oligodendrocytes undergo programmed death during normal development, with only the most successful cells surviving to myelinate axons. Similar percentages apply to many neuronal populations. Environmental insults during critical periods can disrupt these normal apoptotic patterns, either causing excessive cell death in populations that should survive or preventing appropriate elimination of cells that should die. This disruption can lead to both quantitative deficits in cell numbers and qualitative problems in circuit organization that persist throughout life. Gliogenesis represents the other major cellular production line in brain development, running parallel to but distinct from neurogenesis. While neurons get most of the attention, glial cells actually outnumber neurons and perform equally critical functions that directly impact the clinical outcomes we see in preterm infants. Astrocyte development serves multiple essential functions that become clinically apparent when disrupted. These cells provide structural support for migrating neurons, acting like scaffolding during the construction process we discussed earlier. They also regulate the biochemical environment around neurons, controlling everything from ion balance to neurotransmitter clearance. When astrocytes develop abnormally, we see both migration disorders and functional problems that can persist throughout life. Oligodendrocyte development follows a precise maturation sequence that's crucial to understand because different stages have different vulnerabilities. The lineage begins with oligodendrocyte progenitor cells, which then progress through pre-oligodendrocytes, immature oligodendrocytes, and finally mature myelinating oligodendrocytes. Each stage has distinct characteristics and responds differently to injury. Here's the critical clinical point. Pre-oligodendrocytes show peak vulnerability between 23 and 32 weeks gestation. This timing explains why periventricular leukomalacia predominantly affects infants born during this gestational window. Pre-oligodendrocytes are particularly susceptible to hypoxia-ischemia, inflammation, and free radical damage. They haven't yet developed the protective mechanisms of mature oligodendrocytes, but they've moved beyond the resilience of earlier progenitor stages. Growth factors like platelet-derived growth factor and insulin-like growth factor regulate oligodendrocyte maturation. Understanding these pathways opens potential therapeutic targets for protecting white matter development in high-risk infants. Myelination follows a predictable temporal and spatial pattern that directly correlates with functional development, providing a roadmap for understanding both normal development and pathological delays. The process begins in areas that need to function first and progresses systematically toward regions that mature later. Brainstem myelination initiates at 29 weeks gestation, which makes perfect sense from a survival perspective. These are the circuits controlling breathing, heart rate, and other vital functions that premature infants need immediately. The process then advances rostrally, reaching the centrum semiovale by 42 weeks gestational age. This timing explains why term infants show different white matter appearance on MRI compared to preterm infants at term equivalent age. Cerebral hemisphere myelination begins around birth and progresses in a systematic fashion. The sensory and motor systems that infants use most actively receive myelin first, while association areas that support higher order thinking develop later. Most myelination completes by 2 to 3 years of age, but association fiber myelination continues well into adulthood, particularly in prefrontal regions supporting executive function. This progression follows a fundamental principle. Structures that function first are myelinated first. The correlation isn't accidental. Myelination and functional development are intimately linked through activity-dependent mechanisms. Neuronal activity stimulates oligodendrocytes to produce myelin, while myelin enhances conduction velocity and supports more sophisticated neural processing. Environmental stimuli directly influence myelination patterns. Appropriate sensory experiences, social interaction, and cognitive stimulation can accelerate normal myelination, while deprivation or chronic stress can delay it. This relationship explains why developmental care protocols in the NICU can have lasting impacts on white matter development and subsequent neurocognitive outcomes. Synaptogenesis represents the brain's most intensive construction phase, when neurons form the trillions of connections that enable all higher brain functions. Understanding this process is fundamental because synaptic development continues well into the postnatal period, making it both vulnerable to disruption and accessible to therapeutic intervention. The first wave of synaptogenesis occurs during the 3rd trimester, overlapping with the period when many of our high-risk infants are born. This timing means that extremely preterm infants undergo this critical process in the NICU environment rather than the carefully regulated intrauterine space. The implications extend far beyond immediate survival. We're supporting brain development during one of its most active construction phases. Peak synaptic density occurs during the early postnatal period, when the brain actually overproduces connections. This might seem inefficient, but it's actually a brilliant developmental strategy. The brain creates more synapses than it will ultimately need, then uses experience to determine which connections to strengthen and which to eliminate. This leads to synaptic pruning and selective stabilization, processes that continue throughout childhood and adolescence. The pruning isn't random. It follows the fundamental principle that circuits used regularly are strengthened while unused connections are eliminated. This experience-dependent plasticity allows the brain to fine-tune its networks based on the specific environment and experiences each child encounters. We distinguish between experience-independent processes, which follow genetically programmed timelines, and experience-dependent processes, which require specific environmental inputs to proceed normally. Both are important, but experience-dependent processes are particularly vulnerable in the NICU setting where normal sensory and social experiences may be disrupted. Critical periods for sensory system development create windows of heightened plasticity when appropriate stimulation is essential for normal circuit formation. Visual, auditory, and somatosensory systems each have their own critical periods, explaining why early intervention during these windows can be particularly effective. Brain vascular development follows a systematic pattern that directly impacts the vulnerability patterns we observe in premature infants. Understanding this process helps explain why certain brain regions are more susceptible to ischemic injury at different gestational ages. The initial penetration of blood vessels into the primitive neuroepithelium occurs during the peak migration period, creating a complex interplay between developing neurons and their blood supply. Think of this as a coordinated construction project where the infrastructure must develop alongside the buildings it will serve. Initially, vessel density remains quite low with significant distances between individual vessels, leaving large areas of developing brain tissue relatively far from their oxygen and nutrient sources. The penetration pattern follows a specific directional sequence, starting from the leptomeningeal plexus on the brain surface and advancing toward the ventricular system. This outside-in progression creates a temporary period where the periventricular regions, the areas closest to the ventricles, receive the most tenuous blood supply. This anatomical reality helps explain why periventricular leukomalacia predominantly affects the white matter adjacent to the lateral ventricles. Horizontal ramification begins around 20 weeks gestation, creating the lateral branching networks that will eventually supply the developing white matter. The vascular pattern reaches the white matter around this same time frame, but the vessels remain immature and vulnerable. Perhaps most importantly, the muscular arteries lack their normal muscularis layer until the final weeks of gestation. This means these vessels cannot effectively regulate their own diameter in response to pressure changes, making the developing brain particularly vulnerable to both hypotension and hypertension during the preterm period. Cerebral blood flow autoregulation represents one of the brain's most sophisticated protective mechanisms, but understanding its development and limitations is crucial for managing critically ill neonates. Let's break down this complex process step by step to understand both how it works and why it fails. Autoregulation maintains constant cerebral blood flow across a range of systemic blood pressure changes. Imagine a sophisticated thermostat that automatically adjusts heating and cooling to maintain a constant temperature. Autoregulation works similarly for brain blood flow. When blood pressure rises, cerebral vessels constrict to prevent excessive flow. When pressure drops, vessels dilate to maintain adequate perfusion. The mechanism operates through intrinsic properties of arterial smooth muscle cells that respond directly to transmural pressure changes, the pressure difference across the vessel wall. These smooth muscle cells can sense when pressure increases and automatically adjust their tone to compensate. This isn't a conscious process or one controlled by the nervous system. It's a fundamental property of the vessel wall itself. The system balances endothelial constricting factors, like endothelin, against relaxing factors like nitric oxide. Think of this as a continuous tug-of-war, where the outcome determines vessel diameter and blood flow. In healthy, mature vessels, this balance responds appropriately to pressure changes. However, autoregulation has both upper and lower limits of effectiveness. When systemic blood pressure exceeds the upper limit, vessels cannot constrict enough to prevent excessive flow, leading to potential brain injury from hyperperfusion. When pressure falls below the lower limit, maximal dilation cannot maintain adequate flow, resulting in ischemia. Most critically for our patients, when these limits are exceeded, cerebral blood flow becomes pressure passive, directly dependent on systemic blood pressure without protective autoregulation. In premature infants, these autoregulatory limits are both narrower and shifted compared to term infants, creating windows of vulnerability that directly impact our blood pressure management strategies. The development of cerebral autoregulation follows a predictable maturational timeline that directly impacts our clinical management of preterm infants. Understanding these developmental differences helps explain why blood pressure management strategies that work for term infants may be inadequate or even harmful for preterm patients. Autoregulation in neonates is demonstrably less effective than in adults, with the degree of impairment inversely related to gestational age. The sophisticated smooth muscle responses and endothelial factor balance we discussed earlier simply haven't fully developed in preterm infants. This creates a clinical reality where the protective mechanisms we rely on in older patients are either absent or significantly compromised. Pressure-passive circulation becomes the predominant pattern in preterm infants, particularly those who are critically ill. Think of this as losing the protective thermostat function. Cerebral blood flow rises and falls directly with systemic blood pressure changes without the buffering effect of autoregulation. Research has demonstrated a direct linear relationship between blood pressure and cerebral blood flow in these vulnerable patients. The clinical implications are profound. Small drops in blood pressure that would be well tolerated by a term infant with intact autoregulation can cause significant cerebral hypoperfusion in a preterm infant with pressure-passive circulation. Conversely, blood pressure elevations that seem modest can result in cerebral hyperperfusion and potential hemorrhagic complications. Healthy term infants demonstrate a wide autoregulatory range, providing substantial protection against blood pressure fluctuations. However, maturation of autoregulation occurs progressively with advancing gestational age, meaning our most premature patients have the least protection when they need it most. This developmental timeline directly influences our approach to blood pressure targets, fluid management, and cardiovascular support strategies in the NICU setting. Multiple perinatal conditions can further impair the already compromised autoregulatory capacity of neonates, creating compounding vulnerabilities that significantly increase the risk of brain injury. Understanding these risk factors helps identify which patients require the most aggressive neuroprotective strategies. Severe perinatal asphyxia represents one of the most potent disruptors of cerebral autoregulation. the hypoxic-ischemic insult damages the smooth muscle cells and endothelial function that normally control vessel diameter. Even after initial resuscitation, these patients often demonstrate prolonged periods of pressure-passive circulation that can persist for days or weeks. Chronic intrauterine hypoxia and growth restriction create similar impairments through different mechanisms. These conditions often result in adaptive changes to cerebral blood flow patterns that, while initially protective, can leave the autoregulatory system less responsive to acute changes in blood pressure. Congenital heart disease presents unique challenges because the underlying cardiac pathophysiology often creates chronic alterations in cerebral perfusion patterns. The combination of abnormal systemic circulation and impaired autoregulation creates particularly high risks for both ischemic and hemorrhagic brain injury. Head trauma, even relatively minor injuries, can disrupt autoregulation for extended periods. Perhaps most concerning for our NICU population, even mild hypercapnic acidosis can significantly impair autoregulatory function. This means that subtle changes in ventilation management or mild respiratory acidosis can have disproportionate effects on cerebral blood flow regulation. The clinical significance extends beyond immediate care. Patients with impaired autoregulation demonstrate greater mortality and increased rates of brain injury across multiple outcome studies. However, some interventions can help preserve autoregulatory function. Delayed cord clamping has been shown to improve autoregulation, likely through better initial blood volume regulation and reduced hemodynamic instability during the transition to extrauterine life. The 23 to 32-week gestational age window represents the perfect storm of developmental vulnerabilities that creates the highest risk period for brain injury in preterm infants. Understanding why this specific timeframe is so critical helps guide both preventive strategies and targeted interventions. Cerebrovascular immaturity during this period manifests in several ways that compound each other's effects. Arterial end zones, areas where different vascular territories meet with minimal collateral circulation, remain prominent throughout this developmental window. These watershed regions receive the most precarious blood supply and become the first areas to suffer when perfusion pressure drops. The deficient autoregulation we've discussed reaches its most pronounced form during this period. Pressure-passive circulation isn't just common, it's nearly universal in sick infants within this gestational range. This means that virtually every change in blood pressure, whether from medical interventions, handling procedures, or disease processes, directly translates into changes in cerebral blood flow. White matter vulnerability peaks during this same time frame because pre-oligodendrocytes reach their maximum density and susceptibility. These cells haven't yet developed the protective mechanisms of mature oligodendrocytes, but they've moved beyond the resilience of earlier progenitor stages. The combination of vulnerable cells and unstable blood flow creates the perfect conditions for periventricular white matter injury. Germinal matrix fragility adds another layer of risk through vulnerable capillary beds that lack adequate structural support. The germinal matrix continues active neurogenesis during this period, requiring high metabolic demand and blood flow, but the vessels supplying this region remain immature and prone to rupture with pressure fluctuations. The periventricular location where most injury occurs represents the convergence of multiple watershed areas, regions where vascular territories meet and blood flow is most tenuous. When you combine immature vessels, deficient autoregulation, vulnerable cell populations, and watershed anatomy, you create the conditions that make this gestational window uniquely dangerous for brain injury. Understanding cellular vulnerabilities during the critical 23 to 32-week period requires examining the specific mechanisms that make certain cell populations particularly susceptible to injury. Each cell type has distinct vulnerability profiles that help explain the patterns of brain injury we observe clinically. Pre-oligodendrocytes represent the cellular population at greatest risk during this developmental window. These cells face a triple threat of vulnerability mechanisms. First, they're highly susceptible to oxidative stress because they haven't yet developed mature antioxidant defense systems. When free radicals are generated during hypoxic-ischemic events, pre-oligodendrocytes lack the protective mechanisms that mature cells use to neutralize these damaging molecules. Second, pre-oligodendrocytes express high levels of AMPA kinase and NMDA receptors. making them vulnerable to excitotoxic cascade activation, when these receptors are overstimulated during ischemic or inflammatory conditions. They trigger a cascade of intracellular events that ultimately leads to cell death. This mechanism explains why even relatively brief hypoxic episodes can cause disproportionate white matter injury in preterm infants. Third, hypoxic-ischemic insults affect pre-oligodendrocytes more severely than other cell types because of their high metabolic demands and limited energy reserves. These cells are actively differentiating and producing myelin precursors, processes that require substantial energy expenditure. Subplate neurons add another layer of vulnerability. These temporary neurons play crucial roles in establishing proper cortical connections, but they remain present until term gestation. Their prolonged developmental timeline means they're exposed to potential injury throughout the high-risk period. When subplate neurons are damaged, the resulting connectivity problems can have lasting effects on cortical organization. GABAergic interneurons, which provide inhibitory balance in neural circuits, show particular susceptibility to inflammatory damage. Maternal infections, chorioamnionitis, and postnatal inflammatory conditions can preferentially damage these cells, leading to an excitatory-inhibitory imbalance that may contribute to later neurodevelopmental problems. Axonal development represents another vulnerable process that can be disrupted by early injury. The growing axons that will eventually form the brain's white matter tracts are particularly sensitive to inflammatory mediators and hypoxic conditions during this critical period. Environmental factors exert profound influences on brain development, particularly during critical periods when developmental processes are most active and vulnerable. Understanding these factors helps us recognize both modifiable risks and opportunities for intervention. Maternal health serves as the foundation for optimal fetal brain development. Maternal nutrition directly affects the availability of essential building blocks for neural development, from basic macronutrients to specific micronutrients like folate, iron, and omega-3 fatty acids. Maternal infections can trigger inflammatory cascades that cross the placental barrier and directly affect fetal brain development. Even seemingly routine maternal medications can have unintended consequences on developing neural systems, particularly when exposure occurs during critical developmental windows. Intrauterine infection represents one of the most potent environmental disruptors of normal brain development. These infections don't necessarily cause direct tissue damage. Instead, they trigger inflammatory cascades that alter the normal developmental trajectory. The fetal immune response to infection can persist long after the initial infectious stimulus has resolved, creating a prolonged inflammatory environment that affects multiple developmental processes simultaneously. Hypoxic-ischemic insults demonstrate how a single environmental factor can have cascading effects across multiple developmental processes. Beyond the immediate cellular damage, these insults can disrupt the timing of developmental events, alter the normal progression from one developmental stage to the next, and create long-lasting changes in gene expression patterns. Therapeutic interventions, while often life-saving, can also function as environmental factors that influence brain development. Antenatal steroids, supplemental oxygen, and various medications all have the potential to alter normal developmental trajectories. Understanding these effects helps us optimize therapeutic approaches to maximize benefits while minimizing unintended developmental consequences. The concept of epigenetic modifications provides the molecular mechanism by which environmental factors can alter gene expression without changing the underlying DNA sequence. These modifications can persist long after the initial environmental exposure, creating lasting changes in how genes are expressed throughout development and even into adulthood. Perhaps most concerning, some epigenetic modifications can be transmitted to subsequent generations, meaning environmental insults during critical periods may have transgenerational consequences. The critical period concept transforms from theoretical framework to practical clinical tool when we understand how to apply it in real-world NICU settings. These concepts directly guide our timing of interventions and help explain why identical treatments can produce vastly different outcomes depending on when they're implemented. Sensitive periods represent windows of maximal plasticity and vulnerability when the developing brain is most responsive to both positive and negative environmental influences. Think of these as periods when the brain's developmental programs are most malleable. They can be enhanced by appropriate stimulation or disrupted by adverse conditions. The key insight is that these windows don't remain open indefinitely, which creates both opportunities and urgency for intervention. Experience-expectant development requires specific environmental inputs to proceed normally. These are developmental processes that evolution has programmed to depend on predictable environmental features, things like visual stimulation for proper visual system development or social interaction for language acquisition. When these expected inputs are absent during critical periods, normal development cannot proceed, even if the inputs are provided later. Experience-dependent development represents a different mechanism where individual experiences shape neural connections in ways that reflect each person's unique environment. This process allows the brain to fine-tune its organization based on the specific demands and opportunities each individual encounters. Understanding this distinction helps explain why some developmental problems can be prevented with timely intervention while others require more intensive remediation. The therapeutic implications are profound. Timing of interventions can be as important as the interventions themselves. Neuroprotective strategies show maximum effectiveness when implemented during critical periods before permanent structural changes have occurred. This creates clinical imperatives for early identification of at-risk infants and rapid implementation of protective measures. Perhaps most importantly, the critical period concept helps explain why early insults can have lasting effects that persist well beyond the immediate injury period. When developmental processes are disrupted during critical windows, the effects can cascade through subsequent developmental stages, creating long-term consequences that may not become apparent until years later. This understanding emphasizes the importance of comprehensive follow-up and the potential value of early intervention strategies that can help optimize outcomes even after initial injury has occurred. Preterm brain developmental disruption represents one of the most complex challenges in neonatal medicine because multiple critical maturational events occur simultaneously during the preterm period. Understanding this complexity helps explain why preterm infants face such unique neurodevelopmental risks and why interventions must address multiple systems concurrently. Think of normal brain development as a carefully choreographed construction project where different work crews must coordinate their activities precisely. During the preterm period, we see sequential waves of late neurogenesis continuing to produce new neurons, gliogenesis ramping up to create supporting cells, and both glial and neuronal populations undergoing crucial maturation steps. Each of these processes has its own timeline and requirements, but they're all happening within the same developing brain tissue. Simultaneously, synaptogenesis begins forming the trillions of connections that will enable brain function, while early myelination starts to insulate and speed up neural transmission. These coinciding processes create a period of extraordinary developmental activity where the brain builds its infrastructure and establishes its communication networks concurrently. When preterm birth disrupts this coordinated development, the consequences extend far beyond individual cellular damage. The disruption leads to aberrant neural network establishment, where connections form inappropriately or fail to form when they should. Preterm birth fundamentally alters the precise organizational patterns that enable efficient brain function. The connectivity issues that result impact both gray and white matter development in ways that can persist throughout life. Gray matter regions may develop abnormal internal organization, while white matter tracts may follow aberrant pathways or fail to achieve proper myelination patterns. These structural alterations translate directly into functional implications, creating altered brain function patterns that manifest as the neurodevelopmental outcomes we observe in preterm survivors. The key clinical insight is that preterm brain injury disrupts an incredibly complex developmental process at its most vulnerable stage, with consequences that ripple through all subsequent development. The foundational concepts we've covered reveal why timing is everything in neonatal neurodevelopment. Neural tube formation during weeks 3 and 4 represents the first critical window where failure results in neural tube defects that can be prevented with periconceptional folic acid supplementation. The migration window from 12 to 24 weeks creates the next vulnerability period where disruptions cause cortical malformations like lissencephaly and heterotopias. Understanding this timing helps explain the neuroimaging findings we see in infants with early gestational insults. The vulnerability peak at 23 to 32 weeks represents the perfect storm for white matter injury, combining immature autoregulation, vulnerable pre-oligodendrocytes, and fragile germinal matrix vessels. This knowledge directly guides our neuroprotective strategies for extremely preterm infants. Autoregulation maturity develops progressively with gestational age, but becomes further impaired during illness, creating the pressure-passive circulation that makes blood pressure management so critical in this population. Most importantly, multiple overlapping critical periods create windows of both plasticity and vulnerability throughout development. Environmental factors can modulate genetic programs during these windows, with early developmental disruptions potentially affecting lifelong outcomes. This understanding emphasizes why comprehensive neuroprotective care during these critical periods isn't just about immediate survival. It's about optimizing the developmental foundation for an entire lifetime.